Good afternoon and welcome to today's webinar, Under the Influence and On the Clock, Opioid Abuse in the Workplace. My name is Sarah King. I'll be your moderator today. I'm at NORC at the University of Chicago. Should you have any questions following today's webinar or would like any technical assistance regarding SBIRT implementation, please feel free to contact any member of the SBIRT team here, as well as myself at king-sarah@norc.org. This webinar is produced in partnership with the Brief Intervention Group, or the BIG Initiative, NORC at the University of Chicago, and the National SBIRT ATTC. Today's webinar is part of our 2016-2017 webinar series. We're anticipating some great webinars for this year's series covering some hot topics, as well as a mini-series on IPV and SBIRT starting in January 2017. You can also view any of our recorded webinars on our website. All of the materials for today's webinar, as well as previous webinars, are available on our website. We have a dedicated page specifically for today's webinar. You can find the PowerPoint slides there available for download, as well as any additional resources will be posted following today's webinar on this page. You can also access the webinar recording and any CEU information here. Today's webinar is approved for 1.5 CEHs. During the webinar, you can ask questions through the question pane. It's located in the GoToWebinar dashboard. At the end of the webinar, we'll have a Q&A session during which we will address any questions that have been submitted in the order that they've been submitted. So please feel free to submit them as they come to you. We hope to get through all of the questions, but should we run out of time, we want to get to as many as possible. So as soon as they come to you, submit them to that questions pane so we can get to them in order. Behind the scenes today is our technical facilitator, Misty Story. If you have any technical concerns, Misty will be available to assist you. And now I'd like to introduce our presenter for today. Misty Aberg is the Program Manager for the Substance Use, Misuse, and Abuse Prevention Program for Working Adults. Misty has a Bachelor of Science degree in Criminal Justice and a Master of Science degree in Organizational Leadership. Misty is trained in screening, brief intervention, and referral to treatment, and is a substance abuse prevention skills trainer. Misty has worked in the prevention field for nearly 2 decades and is committed to enhancing substance abuse policies and implement evidence-based practices in the workplace to reduce substance abuse. It's my pleasure to welcome today's speaker, and Misty, if you're ready, I'll turn things over to you.
Great, thank you, Sarah. It's a pleasure to be with all of you today. Thank you for those of you on the line, and thank you, Sarah, for the introduction. I always cringe a little bit when people say, and there's 2 decades of experience, because it ages me a little bit, but thank you for that introduction. So I work for Peer Assistance Services for the Substance Use, Misuse, and Abuse Prevention Program for Working Adults. That is a mouthful. The program provides Colorado employee and employers education, employee assistance program guidance, drug-free workplace policy consultation, and we are a statewide initiative, so it's my responsibility to reach as far across the state of Colorado as I can. Our funder is the Colorado Office of Behavioral Health, and they support and monitor substance abuse community programs and providers. There's actually a number of those in our state. So a quick rundown of the objectives for this afternoon. We'll examine the scope and consequences of the opioid misuse epidemic. We'll identify strategies, industries at higher risk of opioid drug abuse use in the workplace. And lastly, we'll acknowledge current and future critical issues for workplace prevention. I always feel it's necessary to start any conversation about prescription use, misuse, and abuse by saying prescription medications do contribute to favorable outcomes and quality of life when those are used correctly and when folks are not using those while performing safety-sensitive work. I think creating awareness of the dangers of prescription drug misuse and its impact on the workplace should be done in such a way that we don't add to the stigma of substance use disorders. Definitely supporting those in need of intervention and treatment is the most important thing we can do. Equally important to just go over, I think, is the language we use when we talk about substance use.
It seems like we're having technical difficulty. Are you moving your microphone? Misty, can you hear me? I'm sorry, folks. We're just having a little technical difficulty. Hang tight with us. Misty, can you hear me? Testing. Misty, can you hear me?
Thank you to our audience on the line. If you could just give us a few minutes while we sort out the audio, we appreciate your patience.
Hi, Misty, can you hear me? Misty, can you hear me?
I just called in. Now I can hear you.
That's wonderful. We can hear you. Please go ahead.
Thank you. So as I was saying, I think it's equally important to understand the language that we use when talking about substance use disorders. So when we talk about misuse of a drug, that's basically when someone is using it for the purposes it's not intended for. Misuse involves not following the medical instructions. Not that a person is intentionally trying to get high off of the substance, but rather more about thinking, oh, I took one of my sleeping pills, I can't fall asleep, so maybe I'll take one more and that'll do the job. Abuse typically means a person does not have a valid prescription and also is using the drug to experience feelings of euphoria or being high. The abuse of opioids, however, as we know, frequently leads to dependence and eventually perhaps a substance use disorder. The SBA makes the note that the key difference between abuse and misuse is the individual's intentions when taking the drug. So, to the meat of our presentation, looking at the scope and consequence of the issue. I think it's pretty difficult not to be somewhat aware of the opioid abuse crisis in our country. So many news stories all over the place. Most recent and tragic story I saw was about a husband and a wife who overdosed in their car while their 3-year-old child was in the back seat. And first responders, of course, had to revive them, and just really very, very tragic. The National Safety Council refers to the current situation as the deadliest drug crisis in U.S. history. The Center for Disease Control says this is a public health crisis. So many prescriptions were written in 2013 that every American adult could have their own bottle of pills. So what that means is that there are 240 million people who could have their bottle of pills. The let me move my slide forward. Hang on. Move forward one more. So, the American Society of Addiction estimates that employers, which insure about half of all Americans, are losing about $10 million each year from lost work and productivity. All drugs combined, overdose deaths in the U.S. outweigh the number of firearm deaths and motor vehicle crashes. So in 2015, there were almost 13,000 gun deaths, and in 2014, almost 33,000 people died in car crashes. So we're looking at over 45,000 people who have overdosed on substances. Employers are noticing this to some degree. A survey conducted by the National Safety Council says that 4 out of 5 employers actually have observed some type of opioid-related issue in the workplace. Many supervisors would say that they don't feel confident in really recognizing the signs of opioid use at work. And what's again so important to remember is that the high that can be produced by opioids in the brain is so extremely addictive that it sometimes causes measurable symptoms of dependence in less than 72 hours. Side effects definitely vary person to person, but most likely would include drowsiness, lethargy, paranoia, nausea, respiratory depression, physical signs, somewhat the same, confusion, very constricted pupils, noticeable euphoria or elation, probably slow breathing, and constipation. There was a story I came across while doing research for this about a woman who is in recovery, but was telling her story of really going to work every day for a long period of time under the influence of Percocet. She said she would, be standing at the copier, making her copies, getting ready for presentations, give presentations. Nobody was the wiser, but she couldn't even remember the presentations that she'd been given. The fact is nobody noticed. Nobody noticed. Workers' compensation, they report that 65 to 85% of injured workers in most states actually have received narcotic painkillers. This comes from a Cambridge, Massachusetts study from the Workers' Compensation Research Institute. So that's out of 264,000 workers' comp claims. And again, these injured workers are receiving these narcotic painkillers from their physician. They're taking them as prescribed initially, but there's so much work that has to go into continuing to learn how to spot the signs of opioid misuse or dependence, and how employees document these observations. It's all very critical work. So definitely with certain types of work come an increased risk for opioid use. It's hard to pinpoint why that's always the case. I think you could consider region of the country or state. I think a person's rank in the industry might speak to their risk of use, increased risk of use. Gender, maybe. Perhaps the rate of pay. And maybe even the job itself. Is it a very repetitive job? Do they do the same task over and over? All of these things could possibly contribute to the fact that there definitely are industries that have higher risks of use. So what type of work does matter? Who is at risk? We see that construction workers, move slide please. We see that construction workers are at about 15.6% use, sales people, a little over 11%, food prep, wait staff, bartenders, also in that category would probably be entertainers, art people, a little over 11% as well, handlers, laborers, helpers, over 10%, and again that might be some of the folks who are performing repetitive tasks. Machine operators and inspectors, that's 10.5%, and of course that's concerning because when you think of a machine operator, that's most likely a safety-sensitive position, and if we're seeing that number of folks who are at risk to use substances, it's pretty frightening. And not to be forgotten, in a very important population of folks in who might be at higher risk of use is healthcare professionals. They're not immune to this, and the Substance Abuse and Mental Health Services Administration reports literally thousands of healthcare workers, which is anything from technicians to doctors to nurses, who are abusing or dependent on opioids. One of the biggest contributing factors to this issue is the ease of access. Good thing is there are many programs designed to help and rehabilitate these clearly talented healthcare professionals so they can stay employed and eventually be safe to practice again. And I think in the same Substance Abuse and Mental Health report, it talked about a 10 to 15% rate of use in the healthcare profession. Other key insights that are definitely important to consider, especially when we're thinking of what might be successful and the importance of cultural competence, what audience are we trying to address? General statistics beyond industry talk about baby boomers being nearly 4 times likely to abuse opioids than millennials. So that's comparing a little over 7%, millennials are 2%. Patients living with lower incomes are twice as likely to abuse prescription painkillers as individuals in higher income areas. Another interesting fact, opioid abusers are more likely to live in the rural South. 22 of the top 25 U.S. cities for opioid abuse are primarily rural and again located in southern states. I come from rural Colorado, and I know what a significant challenge that is for folks who are in need of treatment. Services are rare and often ineffective. Geography, you're traveling a long way over mountain passes to get to services, so that rural component is definitely important to consider. Among the top 30 largest U.S. cities, there's 8 of them that have a higher opioid abuse rate. And again, it's hard to pinpoint why this is, but in order, those 8, Las Vegas, Charlotte, Kansas City, Portland, Tampa, Indianapolis, Orlando, and San Antonio. So some of you might be calling in from those areas, and you may have some insight as to why there's a higher than average opioid abuse rate in your area, but I thought that was an interesting ranked list. Challenges. There's lots of them. Things like balancing pain management and safety. Again, the social stigma of substance use disorders and pain management. Certainly all are part of this section. For some injured workers, opioid use, initially prescribed, and they're using it as prescribed, definitely can be a slippery slope to dependence. From a workers' comp perspective, opioid abuse can extend the life of a workers' comp claim and delay a worker's return to the job. A claim is 30% less likely to close within 90 days if opioids were prescribed in the first 4 weeks. So again, that balance of safety, pain management, these folks are being prescribed this medication legitimately. It's not the intent to begin to misuse it, but yet it continues to happen. Most employers definitely understand the danger of illegal drugs and how that can look in a workplace, but few really recognize the toll that prescription painkillers can cause. Deborah Hirschman, who's the National Safety Council president and CEO, is who makes note of that, and yeah, those consequences are really not being realized by employers. We have a group in Colorado, Colorado Prescription Drug Abuse Consortium. That's a very active group in the state, and we've most likely worked to get the opioid overdose reversal medication very accessible to folks who may need that, naloxone. I'm assuming most of you would be familiar with that reversal product, and it's probably available in many of your states. Interesting though, naloxone, one of these products, has actually been starting to surface in workers' comp claims. So this product can be prescribed by a doctor if they feel their patient is at risk of overdose. But what's interesting is that a one-time prescription of naloxone certainly doesn't necessarily mean that a patient is struggling with misuse or dependence. Anecdotal reports show that some doctors are more likely to prescribe the opioid antidote as a precautionary measure. But the big takeaway from this, if a patient is at a risk level that necessitates the prescribing of an opioid antidote, I think it really speaks to, we need to examine the continued appropriateness of the opioid treatment that's in place. Another serious challenge, unmet treatment needs. Like I just mentioned, definitely in rural areas. Sadly, almost half of the men and women in need of treatment for substance use disorders don't get that treatment. And my first thought was, well, they are lacking insurance, which isn't entirely true, because almost half of the individuals in need of that treatment actually do have private insurance. Perhaps the issue lies more in a lack of education about what treatment is available, again, access to treatment. And of course, we have to consider they could be in denial about their need for treatment. Adequate treatment can also be a factor. Linking back to the workplace, employees who don't receive effective care certainly can become a source of higher costs for their employer. Safety becomes jeopardized, productivity is reduced, absenteeism increases. Another serious challenge would be co-occurring disorders. When you consider 52% of privately insured individuals being treated for substance use disorders also have been diagnosed with at least one mental health disorder, that's challenging. Most commonly diagnosed in conjunction with substance use disorder is depression. And I think we know that drugs of abuse can definitely be the cause of one or more symptoms of another mental health disorder. The increased risk of psychosis in marijuana abusers has actually been offered as evidence of this. And we know that mental health disorders can certainly be caused by substance abuse in that many people self-medicate. Substance abuse and mental health disorders are often caused by overlapping factors. Maybe there's underlying brain deficits or genetic vulnerabilities. Perhaps there's been early exposure to stress and trauma in that person's life. All of this needs to be considered considered when looking at treatment options. We definitely know that there is indeed an opioid health crisis, and I think it's critical that we start really looking at increasing protective factors that can buffer some of the risks that folks that are in place when folks are experiencing higher rates of abuse. Thanks to the Americans with Disability Act and the Drug Addiction Treatment Act that was passed by Congress in 2000, employers are encouraged to support employees with opioid dependency. And another even more important mandate, I think, is the Parity Act. Parity meaning that financial requirements like copays and treatment caps and number of visits allowed must be comparable for physical health and mental health and or substance use disorders. Parity can also apply to how treatment is accessed and even under what condition treatment can be covered. So some examples of how parity protections might benefit you or clients. The plans must apply comparable copays, again, for mental health, substance use care, and physical health care. There can be no limit on the number of visits for outpatient mental health substance use disorder care if there's not visit limit for outpatient physical care. Prior authorization requirements for mental health and substance use services must also be comparable to or less restrictive than those for physical health services. Since the passage of the Mental Health Parity and Addiction Equity Act in 2008, health insurers and employers have certainly made progress toward improving coverage for health and substance use issues. Most insurance plans, for example, no longer charge higher copays or separate deductibles for mental health care, but there's still been some significant problems with the parity law, including lax enforcement, very little guidance to the public about the law itself or how one would go about filing a complaint. Interestingly enough, over the past about 7 or 8 months, the task force working on this issue received over 1,000 public comments from patients and families and insurers, state regulators, advocates. And based on their findings, this group has really taken serious these comments and is moving forward in, I think, a positive direction. So the Centers for Medicare and Medicaid are now awarding $9.3 million to states to help enforce parity protection. Good news, California, New York, Massachusetts, Oregon, and Rhode Island have been cited as models of really promising enforcement efforts. A new government website will be in place to help consumers identify the right agency to assist when they have parity complaints and or appeals. Another great product coming out of this is a newly released consumer guide that can help patients and families and even providers understand their rights and look into whether they have perhaps experienced a parity violation. The Department of Labor will report each year on its investigation into parity violations. And lastly, the task force is recommending that the government increase its capacity to audit health plans for parity compliance and allow the Department of Labor to assess civil monetary penalties when there are violations. Well, prevention certainly remains our best strategy in fighting the epidemic. It's important to understand that even when individuals are deep into the disorder and or dependence, at any stage intervention, even at this stage, can certainly have a positive impact. Substance use disorders are complex and chronic diseases, but we're comparing these to cancer or diabetes or HIV, and they must be treated with the same level of persistence. Just as cancer treatments must be selected according to a person's history or patient characteristics, a substance use disorder treatment plan has to take into account those very same things. And while relapse rates can be certainly disheartening, I think it's important to keep in mind that they are similar to relapse rates in other chronic conditions such as diabetes, hypertension, or asthma. They're obstacles that can be overcome, though, as they are with most chronic disease. You'll hear me or have heard me refer to the National Safety Council a lot. I find that they have incredible resources, and they've put out a statement on opioids in the workplace, and they recommend that employers use a comprehensive approach, is their term. So what does a comprehensive approach look like? Several components to a comprehensive approach. And to kind of put it all in a nutshell, we're talking about drug-free workplace policies, which is most definitely a written policy with employee education, supervisor training, employee assistance programming, drug testing. All of these need to be compiled into a well-written drug-free workplace policy that a company can, and a company needs to realize that they can face significant liability issues if they're conducting drug testing without these policies in place. Clearly the policy helps in unemployment claims and or workers' compensation claims. So whether it's, you have one in place and it needs updated or there isn't one at all, I think that's certainly an important direction to go in. Employee awareness of the issue, employer awareness of the issue really can create opportunities for the issue to be addressed, and then the likelihood of those folks getting into treatment and being successful is substantially increased. So training, employee and supervisor. Clearly, what good is a drug-free workplace policy if nobody in the company knows what it is, how it got there, what they do with it? Clearly, the policy is an important component of preventing drug abuse in the workplace. But employees need to know the harmful effects of drugs. They need to know that help is available and how to access that help. I know in our program we do even we do a variety of the trainings, and it might not be I'm going in and here's the signs and symptoms of opioid dependence, but also things like resiliency training, sleep deprivation, and how that can increase risky behaviors. I know here in Colorado we have a lot of coal mines, and there's rotating shift work, and that in and of itself is a risk factor to increase the likelihood of somebody developing substance use. So I think a lot of employee education opportunities are out there, and when possible, when you can sit down with a company and say, let me meet you where you are. What's the culture of your organization? What are the norms within this organization? And really communicate with them and put together some effective training for their employees. Equally important, without supervisor training, again, your leadership team has, they're not going to adequately be equipped to recognize the signs and symptoms of drugs and or alcohol at work. And we know that leads to unsafe working conditions, and employees who are at work under the influence clearly would need to be removed from the site and required to take a drug test. There's so many opportunities for whether it's a live training, webinar training, computer-based training, where employers and employees can certainly start some of these trainings. And I'm guessing, again, my National Safety Council would have some great resources on their side about this. Also, I think important is a very clear understanding to employees of drugs that are not allowed at all due to safety-sensitive positions. And definitely it's important to remind workers about safe storage and disposal of medications. So I think one of the biggest pieces of a comprehensive drug-free workplace policy is an employee assistance program. So commonly known, like EAP is what we call them, and employers really don't have to spend a ton of money to get an EAP program in place. We're looking at a return on investment of, for every $1.50 spent by an EAP, there's $13 in savings when it comes to lost productivity and absence and presenteeism and workplace safety. So pretty good return on investment there. Many health insurance programs include EAPs in their benefit packaging now. EAP agencies can provide employee assistance as part of the company's drug-free workplace program, or even maybe through their wellness program. I know that's how we are successful getting this information into a lot of companies, is incorporating it into their wellness program. It seems like, yeah, the economic cost savings there definitely is worth EAP investment. Really important are the components of a comprehensive employee assistance program. In place is a core technology that represents the very essential components of the employee assistance profession. We as EAP providers, we have a unique approach to addressing work organizational productivities and employee client personnel concerns that would affect job performance. And I want to run down, and it's a list, but I think it's worth going through the EAP core technologies. So first of all, consultation with, training of, and assistance to work with organizational leadership, which would be managers, supervisors, union officials, who are seeking to manage troubled employees and enhance the work environment, thus improving employee job performance and ultimately the bottom line of the agency. Active promotion of the availability of employee assistance services to employers, their family members, and work organizations. Super important. Folks need to know that there's something out there, how to get to it, and that it's going to work for them. Confidential and timely problem identification and assistance services for employee clients with personal concerns that might be affecting job performance. One of the biggest issues I ran into when I started doing employee assistance professional work is folks really are still very untrusting of that relationship. They don't entirely believe that, well, that my employer provides this employee assistance service, and so somehow they're going to find out what I'm talking to my provider about, which, as we know, is still not true. But I do think there's a lot of work to be done in building the confidence of employees in the process and assuring them that their information is very protected, and the employer, they don't want to know necessarily. They are there to help you and encourage you to get access to help. There definitely is a piece to this that involves use of constructive confrontation, motivational interviewing type thing, short-term interventions with employee clients to address, again, problems that affect their job performance. Another piece of this is referral of employee clients for diagnosis, treatment, and assistance, as well as case monitoring and follow-up. The EAPs aren't providing the treatment, but they are the ones doing the referring. Another piece is assisting work organizations in establishing and maintaining effective relationships with treatment and other service providers. I know in my neck of the woods that there's a certain EAP that we work with, and I made it a priority to go meet those affiliate providers so I could give employees accurate information about who was out there available to see, and did they, would they complement the culture of an organization or be able to meet an employee where they are. And I feel that allowed me to provide more accurate information to employees. And lastly, I think, well, wait, let me back up a little bit. So we definitely want to work with organizations, again, to encourage the availability and employee access, not only to the health benefits that cover medical and behavioral problems, but also substance abuse and mental health disorders. And most important at the end of all of this is evaluation of the effects of employee assistance services on work organizations. I know, again, the work that I've done, it is a priority that we evaluate our services and are we making a difference in the companies that we work with. and we share those results with the companies. For employees who are recovering from dependence or substance use disorder, employee assistance programs really can be an important part of them staying on track with their sobriety. They can decrease the need for inpatient care, definitely reduce costs for services overall, and I don't think EAPs are utilized as often as they can be. I think, again, it could be trust. They're not really aware of the scope of services that the EAP may be offering. Again, negative repercussions if their employer would have access to what they're seeking services for. So I think employers have a big responsibility to make their workers aware of the benefits and certainly the confidentiality of the programs. Last check, it seems that average utilization rates of employee assistance programming is 3.5 to 4.5%, which is super sad to me. These are great resources, and I would love to see that number drastically increase. Know that folks are accessing the great care that is available to them. Another component of a drug-free workplace policy, drug testing. You definitely want to trust your employees, but you also really want to know who among them might be struggling with a substance use disorder or dependence. So drug testing is one way to protect your workplace from the negative effects of drug use. A drug testing program can certainly deter employees from coming to work who might be unfit for duty, who are under the influence. But I think it also discourages folks from joining an organization in the first place. Not great for Colorado is the issue of, given our legalization of retail and medical marijuana, many construction labor type organizations are reporting a lack of employees who can pass a drug test. Sad, not something that we're proud of, but definitely an issue that we need to address. So employers can certainly play an active role in who might benefit from services, whether through the drug testing program or the employee assistance program. Most employers who screen for substance use don't always screen for prescription opioids. And in some cases, it represents an additional cost or a burden to them, but perhaps the employer might believe that it isn't their place to monitor those type medications. If an employee has obtained them legally from a physician and they're using them as prescribed, they would rather stay out of it. But with the growing impact of opioid misuse in the workplace, the potential benefits of screening certainly outweigh some of those reasons that employers might not want to drug test, and that probably really needs to be considered. Employer drug testing programs do have to address the non-medical use of opioids in the workplace. The written policies have to reflect the specific actions that both employees and employers must take. A number of workplace, I'm sorry, I don't believe my slides are moving forward. A number of workplace policies measuring the incident rates of companies before and after implementing drug testing indicate that drug testing is an important factor and in fact has efficacy. One of the most prominent of these studies involved the Southern Pacific Railroad. So following the implementation of drug testing, the incidents resulting in injuries, and this is outstanding, dropped from 2,234 incidents in 1 year before drug testing was in place to just over 300 incidents after the drug testing was put in place. That represents an over 70% improvement, which is phenomenal. So that definitely, to me, speaks to the efficacy of workplace drug testing. Obviously, we are on a call with them, sponsoring this webinar with the National Opinion Research Center, NORC, out of the University of Chicago, and the Brief Intervention Group campaign that engages EAP vendors and professionals to advance the use of SBIRT is one of their goals, and I'm guessing many of you are familiar with SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. It is the most common prevention and early intervention model, and it's been shown repeatedly to be an effective and very cost-efficient way to identify or halt substance use disorders in adults. Basically a series of questions to assess risk and create opportunities to intervene and refer to treatment when needed. It's a conversation. It's looking to have the conversation around substance use be normalized. It needs to become a routine practice. Just as I would go in and have my blood pressure checked, I would like to go in and know that I'm being screened for what could potentially be risky and dangerous substance use. So our efforts in Colorado have definitely been to encourage EAP practitioners to use SBIRT on intake by offering training. We do training for healthcare professionals and affiliate providers across the state. We've been doing this since 2006. A great resource that we maintain is an interactive map that pinpoints SBIRT initiatives across Colorado and the U.S., which serves as a great tool to connect healthcare providers and community stakeholders, policymakers, to explore opportunities that might be there for them to collaborate. Sadly, I have a story of, where every piece of the system really failed. A particular young person in a community that I used to live in. He was a 25-year-old coal mine employee who operated a articulating water truck, if you will, and sadly, he on a Saturday in July of 2012, he received fatal blunt force trauma injuries after he was ejected and run over by the truck he was actually operating. He lost control of the vehicle. The vehicle had rolled backwards after the victim lost control, and he was ejected, and then the truck ran over him. So to me, there's a lot of things that failed. First of all, he wasn't trained in the emergency shutdown of the vehicle. He was not trained in proper seatbelt use. He did not have a seatbelt on. But most importantly were the toxology reports that found the power adjuster, which we use on computers, in his system. And sadly, the can was actually from the mine warehouse itself. So where there should have been a checks and balances in place, where employees didn't have access to that kind of dangerous substance, there was nothing like that. There probably were signs and symptoms of mental health disorders in this young man. Everything just broke down, and sadly and tragically, we lost Jason. It's important to look at the big picture, and when you think about these components that I'm going over, every one needs to be in place with enforcement, and again, written policy, and making sure that employees understand the importance of following these procedures. It's so important. Definitely worth mentioning, I think, is we have the good news and we have the not so good news as we look ahead to address opioid abuse currently and in the future. Sadly, we're moving to a lot of a pill to treat the symptoms of another pill. I don't know how many of you might have seen the commercial for folks who are experiencing constipation due to opioid use as prescribed. Now there's a pill to help that symptom. So it just, are we going in the right direction? I don't know. There are stronger substances coming on board. Rapidly growing danger is the use of the drug called carfentanil, which is a synthetic opioid that is so strong that just a few granules of which basically are the size of table salt can be lethal. Sadly, since mid-August, there's been about 300 people in at least 4 states who have overdosed on heroin that is linked to this substance. And it also in this mixture is the compound fentanyl. The DEA says it's 100 times deadlier than fentanyl, which itself is almost 50 times more lethal than actual heroin. A DEA spokesperson says that it actually only takes a few ingested granules of the substance to kill someone. And in fact, officers and healthcare officials have really had to take extra precautions to protect themselves from accidentally ingesting any of the substance when they're responding to overdose victims. They have fears that they could potentially accidentally overdose themselves. Another not so great part of future is looking at the dangers of unregulated substances. Recently in the news, there's been lots of information coming out about a substance called kratom, which is a tree native to Southeast Asia. The leaves contain mind-altering opioid compounds, and they're basically consumed in a tea-like fashion, and they produce uplifting effects and some pain relief. It also serves as an aphrodisiac. So with prescription drugs now leading cause of death by overdose, some users are, they're looking for ways to turn to natural resources for relief. And they say kratom works. The DEA says otherwise. Kratom was on the DEA's list of drugs and chemicals of concern. Well, it's been there for several years. And on August 31st, the DEA published a notice that it planned to place kratom in the Schedule I drug classification, which is the most restrictive classification of the Controlled Substances Act. Its two primary ingredients will be temporarily placed onto the Schedule I on September 30th, according to a filing by the DEA. Their reasoning clearly was to avoid imminent hazard to public safety. The DEA did not solicit public comments, however, and normally that's something that they do. So the scheduling of kratom did not actually occur on September 30th as previously thought. There were dozens of Congress members and researchers and advocates who really expressed outcry over the scheduling and the lack of public comment. So according to Medscape Medical News, a DEA spokesperson says that even though they do still plan on scheduling kratom, hopefully rather than banning the substance outright, we can look at research that can be conducted on medical efficacy for treatment and then perhaps regulate the medical use by the DEA. Another interesting substance that is being misused, they call this the poor man's methadone. Opioid addicts are turning to this cheap alternative to get high with an over-counter drug. The popular anti-diarrhea drug Imodium AD is the latest trend by opioid-dependent folks to stay high. According to a report published in the Annals of Emergency Medicine, this anti-diarrhea medication is attractive to drug users because obviously it's very available, it's inexpensive, and the main ingredient in the drug, as we know, causes intestinal slowdown, which helps stop diarrhea, but it is also an opioid. Now, it does take a lot of this to produce that high, but it was quite interesting that this is something that folks are now abusing and becoming dependent on. Some positives in terms of current and future developments. Technology is definitely moving in a great direction, and some examples of that would be, and I don't believe Pathways is the only one, but this pain medication DNA insight, which analyzes patients' DNA to identify genetic variants that might affect how they respond to the analgesic effects of pain relief. 13 commonly prescribed pain medications. So how awesome is that there's perhaps this tool that can help inform providers on what might be better to prescribe than other substances. Another great piece of technology is the MAT-X, which is a new mobile app actually available for download, and it empowers healthcare providers to provide effective evidence-based care for opioid use disorders. It's a Fitbit-like device which you wear on your wrist, And this really is being considered as groundbreaking technology in the fight to solve the opioid crisis. Another, I'm really excited about this, the HOPE intervention, which is led by Dr. Sean Young, who's from the University of California Institute for Prediction Technology. He's looking to harness the power of social media to improve public health. Instead of taking a clinical approach to reducing opioid abuse, which often involves prescribing alternative medications such as naloxone, like we talked about, the study really seeks to actually change behaviors using social media. So we've looked at the scope and the consequences and the challenges, and we've identified high-risk industries and seen examples of some successful strategies that could reduce opioid use and impact to the workplace. We've looked at some good and not so good consequences of emerging alternatives. But I think, in summary, I want to leave you with three, let's say, action items. Number one, we've got to inform our actions with evidence. Evidence-based, evidence-based, evidence-based. I don't think I can say that enough. Even though there are a lot of evidence-based interventions that exist that definitely inform addressing the public health emergency well, they do need to be scaled up and more widely disseminated. And although many of the promising ideas are evidence-informed, they've not yet been rigorously evaluated. The urgent need for action requires that we rapidly implement and evaluate these promising practices and programs, I think. And the search for new and innovative solutions has to continue to be supported, things like the social media HOPE project. Secondly, we've got to intervene comprehensively. This means we have to support approaches that intervene along all parts of the supply chain, the clinic, the community, the treatment settings. Interventions have to be aimed at stopping individuals from progressing down a pathway that will lead to misuse and abuse and dependence and disorder. Effective primary, secondary, and tertiary prevention strategies are really vital. The importance of creating synergies across the different interventions to maximize the available resource is definitely a critical piece. Promoting appropriate and safe use of prescription opioids. I know there's a lot of work going on in this area. I hear it and I see it and I read it. By no means, I think, do we want to point a finger at providers, but I think, as we've said, used appropriately, prescription opioids can definitely be a relief to patients, but the therapies, they're being prescribed in quantities and for conditions that are so excessive and in many cases totally beyond evidence-based. These practices and the lack of attention to safe use, the storage and disposal of drugs contribute to the ongoing misuse and abuse and overdoses, which is, they've increased significantly in the past decade. We've got to support efforts to maximize the favorable risk and look at that safety balance of prescription opioids by optimizing their use in circumstances that are actually supported by best clinical practice guidelines. And throughout some of this, I feel as if I'm preaching to the choir, but these are all things that we have to stay at the forefront of our mind. And again, that thought of intervening comprehensively from a number of different directions with a number of different evidence-based strategies is the best that we have toward being successful. So rather than, I had a lot of handouts I wanted to attach to the slides and things that you could print off and download, but I thought probably what made most sense is for me to just list out some of the sites. Again, these are sites that I go to for great information. The National Safety Council being one of my favorites. Institute for Drug-Free Workplace. great information. They have drug-free workplace policy templates and guides and lots of great stuff that can help get things in motion in terms of drug-free workplace policies. The Employee Assistance Professional Association, very important, very great resources on their site. SHRM Online is the Society for Human Resource Management, and again, great resources about substance use, abuse, misuse as it relates to the workplace. They talk a lot about return on investment, your investment in an EAP, what you can expect in increased productivity, presenteeism, less accidents. And the Substance Abuse and Mental Health Services Administration has a plethora of wonderful booklets and guides and brochures that I think for the most part are always downloadable, and most often you can request hard copies of the material for no charge. So I would encourage you to visit those sites, and things that apply to you and your situation in your community, take advantage of those. I've also provided just a list that gives you some additional reading ideas. Some great books, American Pain, Dreamland, interesting study from Johns Hopkins about evidence-based approaches to the opioid epidemic, history on opium, a real story of an addict called Towhead. Another super interesting one is Understanding Pain, neuromodeling. I had the opportunity to attend a recent workshop that talked about brain imaging and how important that's become in helping identify different types of depression and different types of brain activity that will or will not respond to certain medications. It's kind of along the lines of that genetic testing. Such brilliant stuff around neuroscience coming out about how we can better treat substance use disorders. So again, I would encourage you to study these, and again, pick what you need and what might be helpful to you. And there's been I think it's been out for a few years, but it's a video, and although it's primarily focused on teen opioid abuse, it's called Chasing the Dragon, and it's a documentary that's been developed by the DEA and FBI together, and it really explores this epidemic up close and personal. And it's somewhat graphic and definitely hard to watch, but it's informative, it's real, and I would encourage those of you who haven't seen it to check it out. It's available in a couple different formats on YouTube, and I think there might even be one that's less graphic. It's been filtered a little bit, but another very, very interesting resource and an up-close look that perhaps some of us wouldn't otherwise get. So I appreciate your interest in this topic, and I apologize for the technical difficulties that we experienced. I think that just happens sometimes. I encourage you to reach out to me or others in my agency or any of the resources I've listed for you to get more information. And yeah, so thank you again for your time and attention. And Sarah, I'm going to hand this back to you for some questions.
Great, thank you so much, Misty. That was a really great presentation. I just want to remind the audience that you can submit questions to the questions box. I do have a couple in here that we can get started with. So the first one is from earlier in the presentation, and they're asking about the particular areas that you discussed in regards to the boomer demographics. So they're wondering if there are larger populations or larger percentages of the population within those demographics.
I'm sorry, could you repeat the first part of the question?
Sure. So they're wondering, what are the boomer demographics, and are they a larger percentage of the population?
Oh, okay. You know, that is a good question, and honestly, not one that I think I can adequately answer. It's certainly something I could do some research on, and you know, we could provide to you, and you could send out information, but I don't really know.
Okay, well, we can certainly try to connect you after the webinar. If you do find some information on this and you want to send it to us, then we can add it to the recordings website and share that with the attendees.
Great. I'd like to.
Sure. So the second question is, what kind of issues are occurring for employers regarding medical marijuana, and can an employer fire a person who tests positive?
great question. And in Colorado, yes, an employer can terminate an employee for marijuana use. And again, we're still in the throes of researching, measuring the levels of THC in a person's system, but zero tolerance is zero tolerance, and there's been several cases, case law that supports the employer firing, terminating an employee for marijuana use. Like I mentioned earlier, there are so many construction, oil field type companies who are finding it difficult to find employees who cannot pass a drug test, and it's more often than not marijuana that's the issue. So sadly, these industries are looking outside of Colorado to fill these spots, which isn't good for our economy. I think employees still have this assumption that as long as I'm not doing it on work time, they can't terminate me, which again is so wrong. I think the open communication, the reinforcement of drug-free workplace policies, and what zero tolerance means is super important to communicate to employees. And obviously, there'll be industries that this isn't as big of an issue. Perhaps a restaurant may not drug test their wait staff. Maybe they don't feel that they need to, but certainly when I get on an airplane, I want to know that my pilot is not under the influence of anything or has anything in the system. So it does vary industry to industry, but at the end of the day, it's still illegal, and marijuana is still a Schedule I controlled substance. So I hope that answers the question.
Okay. The next question is, are you able to share the data that states that employers are having a struggle to find that employers are struggling to find employees that can pass a drug test?
Yes, that would be something I could provide you after the fact. I have there's a number of articles that I've been gathering where they're interviewing construction companies and HR folks, and there's also some interesting information out of the Society for Human Resource Management that speaks to this as well. So I'm happy to put a list together of those resources for folks to access.
Okay, great. Yeah, if you want to just share those with us, and then we'll post that on the recording page. The next question here is, how does drug testing assist the employer in addressing employee misuse of opioids if they've been legitimately prescribed?
So if they've been legitimately prescribed, how do we address the issue? First and foremost, I think avoiding that judgment and stigma is super important. There are folks who, of course, they've received the prescription legally, they're using it as prescribed, but what is so important is the consideration of safety-sensitive positions, and again, this is information that needs to be included in the drug-free workplace policy. It needs to be written, it needs to be, employees need to read it and sign that they read it, because I mean, again, if I go to the dentist on a Friday afternoon and I'm prescribed a pain medicine and I take it over the weekend, you know, if I take it at 7 o'clock at night and I end up being drug tested Monday morning for whatever reason, although I might not be, my ability might not be, I might not be under the influence or my ability is impaired, but it's still in my system. So I think there's a lot of gray area in that discussion, and it comes down to creating very clear policies and encouraging, you know, your employee, if you've been to the dentist and you've been prescribed this, let us know, and maybe we can re-sign you for the couple days that you feel you need to use it. But yeah, it's certainly an important conversation to have.
Okay, great. I just want to remind everyone, you can keep submitting questions to the questions box. We just have some time left, so keep those questions coming. Misty, could you talk a little bit more about the Fitbit device and what it does to help fight the opioid crisis?
You know, it's so new, and I'll kind of speak to my age a little bit. I'm not that savvy with technology, but it's definitely something I want to explore and learn more about, because you know, the emerging adults ages 18 to 24 is a group that we see with higher rates of drug and alcohol use. And I think anything that's technology-like would really appeal to that audience. So I'm going to get out of my comfort shell and learn something new about technology, and perhaps be able to, share that information more widely with companies that I come into contact with, because I think it really could be successful. And I'm curious about the cost, of course, and if it's something that perhaps would be considered covered by insurance. So I need to learn more about the Fitbit device.
Okay. Can you talk about methadone versus Suboxone treatment as an EAP professional? This person is an EAP professional, and many of their clients are looking for a quick fix, but they're ignoring the treatment part. Do you have thoughts on that?
Well, I have been in and out of conversations about the misuse, if you will, of naloxone, that folks are continuing to use opioids knowing that, well, I have this quick fix and, I can pull myself out of this and yet not, have a consequence or have to participate in treatment. And I think that comes back to providers in that person's life, to pharmacists, to anybody that can speak to the medical dangers of that, and anybody that might have the potential to refer that to refer that person to some intervention and treatment process. Clearly, we know that oftentimes folks in the throes of all this, denial is a big part of it, and the sheer addiction to the substance is incredibly strong, and it's not easy. But I do see that I do hear that naloxone is being, like I said, misused as a quick fix, and yet not often are people getting into the entire treatment program that they need. So I don't think that we should make naloxone less available by any means, but perhaps those providers who are prescribing that might be a connection to help folks take a bigger look at what's going on and encourage them and refer them to other help.
Okay, great. So this question comes from someone who is in a community that's holding opioid forums, and the focus of the forums tends to be on education, treatment, and enforcement. So do you have any suggestions on how to get these forums to recognize the community employers and highlight that they have an important role to play as well?
I think perhaps, not knowing what size of the community it is, but in my area, I work as closely as I can with employee assistance companies, folks who are, overseeing a number of different communities and affiliate providers. And I share a lot of information with them, and they in turn share it with their employers, that whose companies they cover. We're also finding some success working through workforce centers. We've got over 57 of them here in Colorado, and oftentimes employers are advertising through those workforce centers their positions, and they've been very responsive to engaging in the conversation. We've also found a captive audience with temporary employment agencies. I think anywhere that employers are kind of a captive audience, pulling them in and showing them the data and how this is affecting the bottom line of their productivity, they become a little more interested when they see the dollars and cents that go with it. And when you realize that the cost of EAP services isn't near as expensive as I think some of them believe, and showing them that return on investment is super important.
Okay, again, I just want to remind the audience that they can keep submitting questions to the questions pane. Our next question is an EAP program an appropriate resource to refer people to based on an SBIRT survey or a clinician?
Will you state the question again? I'm sorry, I have got a little bit of an echo.
No, sure. So is an EAP program an appropriate resource to refer people to based on an SBIRT survey or a clinician, or should they only refer based off of a clinician?
Well, I think an SBIRT survey is appropriate too. I mean, the EAP is, again, like I said, they're not going to be the ones providing the direct service and treatment, but they will be resource for referral. They will have treatment providers, affiliate providers on their list and be able to help a person locate appropriate services. So I definitely think that EAP is a helpful piece of that.
Okay. Can you talk a little bit about the role of an experienced drug-free peer versus the drug-free professional in helping addicts?
The experienced drug-free peer versus the drug-free professional. I guess I don't understand. I don't clearly understand the question. I'm sorry.
Well, I'll leave it open to the person who submitted this question if you want to just submit some clarification on the two roles that you'd like her to compare. And while we're waiting, I just want to again remind the audience you can keep submitting questions if you'd like. That is our current last question in the queue.
And maybe I can, if I'm trying to understand the difference between drug-free peer and drug-free professional. So I'm assuming.
Oh, I'm sorry. I've got the clarification here. So comparing roles of a peer, so a drug-free peer versus a degreed professional.
Okay. Okay, that's what I thought. I think the influence of a drug-free peer can be significant. I wouldn't say it's better or less than effective as a professional, but we tend to relate to our peers. I think within an organization there's a social norm that may or may not exist around substance use and misuse, and those peers know that. And I think if a peer has a relationship with the person who's experiencing parts of this issue, it's important. Those relationships are important, and even if the peer is only the beginning of the intervention, it just might push that person into seeking the drug-free professional help, and maybe the drug-free peer has had experience with EAPs or something similar, where they can help assure the person that they are helpful services and it is confidential. We look at adolescent. I worked a lot in adolescent substance abuse prevention intervention, and we found that peers were definitely influential and helpful in that age group. But I don't know so much about the adults, but I would think it couldn't hurt.
Okay, well, it looks like that's our last question for today. So I just want to thank you, Missy. That was a great presentation. And if you do have any additional resources you want to share with the audience, feel free to send that to us, and we'll get it posted with the recording and then shared with the attendees for today.
Great, I will do that. Thank you.
Great. So I want to let all of our attendees know that the PowerPoint slides are posted on the website in PDF form, and you can find a certificate of completion available for request on that same site. We'd also ask that you complete the evaluation survey prior to requesting the certificate of completion, and you can find a link to this survey in the chat box right now. The evaluation survey is critical to the success of our project and allows us to continue and maintain our funding so we can provide educational sessions just like this one. So again, thank you for joining us today. I'd like to thank our partners, the Big Initiative, NORC, and the National SBIRT ATTC. And finally, if you have any questions about SBIRT implementation, evaluation, training, or technical assistance, please feel free to follow up with a member of the SBIRT team. We do have a couple minutes left on the webinar today, so feel free to take this time to complete the evaluation survey. Again, that link is available right in the chat box, and we really, really appreciate you taking the time to send us your feedback. We'll hang on the line for a little bit here. If you have any other technical questions, or would like any additional resources, just send us a line.